Good morning, and thank you to all attending people in this main session. I've chosen a small topic about this. I thank you, my collaborators. In the current scenario of diabetic macular edema, there are some still remaining unmet, what we commonly call unmet needs. The different pathophysiologic pathways, not just permeability or primary permeability changes, based on the unpredictable treatment results shown before, even by the previous presentations. And more importantly, we are a very specific area of medicine. We are no more accustomed to find biologically the proof of concept of what we are defining. So there are two situations. One is to improve the number of imaging parameters or biomarkers, as you like, and their quantification, possibly automatic quantification, to avoid that we have just a few biomarkers, and the liquid biopsy approach we need to do. The OCT, the structural OCT in diabetic macular edema shows a lot of possibilities to be analyzed, a lot of parameters to be considered, even if we are still focusing, particularly in clinical practice, particularly even with new drugs, on just one, the thickness of the central subfield. And we are not considering all the other parameters. One of this is an intriguing one and attracted my attention in the last few years, since when Jenniferson wrote about this, is the DRIL, the disorganization of the retinal inner layers in diabetes, which is a sort of fog in the inner part of the retina from the ganglion cell layer to the outer plexiform layer. And it has paid attention. It has been associated with VA, and therefore it may be possibly, you see at the conclusion of my presentation, a surrogate of visual acuity, and it's changing during the natural history. It's associated with other functional parameters that I'll discuss. The pathophysiological remains uncertain. A large part of the literature is oriented toward an ischemic, the impact of macular ischemia on the development of this phenomenon. And the resolution pattern is completely unsolved. So we performed a study. We performed a study putting together a group of patients with a DME that we divided by the presence or not of DRIL. We investigated all the OCT parameters in these patients, as is usual in more accurate studies at the moment, but we added something more. The concept of liquid biopsy we are working on in the last 10 years in diabetic eyes, human eyes, the only reliable model of diabetic retinopathy. And we are doing this after many laboratory studies, sampling the aqueous humor, because it has already been demonstrated that the component, the proteomic in particular, of aqueous humors is the same as the vitreous, which is considered theoretically better. But the two groups are quite nicely distributed. There are no demographic differences between them, and the classification by two independent examiners was quite high about the definition of the central 1 millimeter by the presence of NOT. Very simply, the presence or not of DRIL. We were attracted by the idea to find something more, theoretically, through the biologic approach, the proof of concept. This is the distribution. And you see that the situation is that DME eyes are completely different from controls, as 130 parameters of the aqueous humor are considered through the current laboratory technique. And in particular, I can tell you that all these parameters have been analyzed. But through a multivariate analysis, the surprise was that the only difference we found inside the eye biologically from the no DRIL and DRIL in DME eyes is the concentration of GFAP. The concentration of GFAP depends on the hyperactivity of the Mueller cells. No other stories, no inflammatory biomarkers. So DRIL is included in the 5 OCT parameters for prognosticating the success of the current standard of care in DME by a very nice study performed by some colleagues in Hong Kong a couple of years ago. So it's a part of the parameters we may consider for the future for the visual prognosis. DRIL is associated, the presence of DRIL, with worse baseline and subsequent visual acuity. We are not necessarily contributing, but offering a contribution to the topic very nicely presented by Jennifer before. And this is the evolution that it happens of this component inside the eye. It can resolve over time. This fog disappears slowly, but it depends on the duration of this phenomenon, on the results on the visual function. And what about the hyperactivity of the Mueller cells? It's well known. It's well known inside the human eyes. We are working on this topic more than 10 years. We sample the eyes with diabetes, without diabetic retinopathy, with retinopathy. And we found that there is a progressive increase in the hyperactivation, not death, hyperactivation of Mueller cell inside the eye that we now consider a key actor in the story, in particular, of diabetic macular edema. And at the other time, this graphic is showing you that when diabetic macular edema completely resolved, this is sampling every 3 months for 1 year in patients undergoing one particular treatment, that the normalization of the amount of GFAP and KIR.1, which are the 2 biomarkers of Mueller cells, then we have the complete disappearance and long-lasting disappearance of macular edema. Moreover, a DRIL is significantly associated with metamorphopsia, visual symptom considered in the past just related to vitreoretinal interface, but now we know. And the metamorphopsia has been already shown by some Japanese colleagues that's strictly related to the component of the visual function of the Mueller cells again. So we can briefly discuss the conclusion of the study that we need to identify, from my point of view, the biologic counterpart of the OCT signs we are currently seeing on our examinations. DRIL remains a controversial issue. We have not solved the story. But the liquid biopsy approach we are trying to propose even in the future for the precision medicine approach in DME has shown that it's correlated more to Mueller cell dysfunction than other components inside the retina. Thank you.
Thank you very much for this interesting presentation. Is there a question from the audience? How do you use DRIL, assessment of DRIL now in your daily practice?
This is a nice story because we have investigated in the last few years many parameters to quantify them. Our goal is to be able to quantify automatically the OCT parameters to provide a support to the clinical practice. Unfortunately, DRIL is very difficult to be automatically quantified, and our experience is that it is still something semi-quantitative.
Any other questions? Thank you very much. And I'm happy to introduce our last speaker, Professor Reak from